Nick, thanks for that wonderful introduction. And for all of us here, the faculty, we are so excited to be part of TIO. This meeting continues to grow, and the fact that there are more than 6,000 people who have joined the meeting is super exciting. We're hoping this first session will be very exciting. We'll get you really into structural heart with one of, I think, the very exciting new innovative areas, which is the atrioventricular valve, that is the mitral and the tricuspid valve. But we also need to go beyond just talking about edge-to-edge repair and talk about what kind of place replacement will take. And there's no better place like TIO to get into sort of innovative, novel technologies. So for this session, let me introduce you to my outstanding panel. I'm really delighted to be joined by world experts who I can also call friends, and they're really an incredible faculty. So Didier Cheche from Toulouse, France, Kendra Grubb from Atlanta here in the US. Kendra, don't feel shy being our only surgeon. I know you won't. Keep us, make sure we have the surgical input and everything. Lars Sondergaard from Copenhagen, Denmark. And then Holger Thiel from Leipzig in Germany. And along with them, we'll be getting really into some of the intricacies of these novel technologies and where they fit. But maybe to start it all, Kendra, why do we need a valve replacement? I mean, we have edge-to-edge, it's safe, it's great. We can use it in most patients. And you know, for many people, they don't feel like they need other technologies. So maybe you'll talk about some of the unmet needs that there are as regards to the mitral valve and edge-to-edge. Thank you.
Yeah, certainly. As a surgeon, this is particularly important because as we not only have unmet needs with TEER, we also have unknowns for patients. And so thank you for this opportunity to discuss unmet needs in the TEER era. So here are my disclosures. So we're going to start with secondary mitral regurgitation because this is something that doesn't have the strong surgical precedent and also has the most recent data. So secondary mitral regurgitation in the guidelines is really something that TEER is appropriate for patients who, after maximize guideline-directed medical therapy, they're still symptomatic. In the US guidelines, low EF, and then their anatomy is similar to COAPT, where I'm headed next to explain what that means, then they're candidates for transcatheter edge-to-edge repair. But you can see surgery still has a place for many patients. In the European guidelines, very similar, slightly different algorithm, but the basic design is the same. For those patients who have secondary mitral regurgitation that are not surgical candidates that would benefit anatomically from TEER, then TEER is appropriate. And one of the concerns I have is, what does anatomical benefit or anatomical candidacy truly mean? And we think about where the data comes from. It comes from COAPT, and we're really fortunate in that the 5-year data was just released at ACC literally 2 weeks ago and presented by Greg Stone. Just a quick background, the 2-year endpoint, at that point, TEER showed improved 24-month survival, reduced hospitalization, and improved quality of life. At the 2-year point, there was a crossover. So you'll see that in the data that I'm presenting, you'll notice an inflection point. But we have to remember who were excluded. And for these patients, they were maximally optimized on guideline-directed medical therapy and then still had heart failure symptoms. In addition, there were exclusions. And one of the important ones from a surgical standpoint is concomitant valvular disease. And so these patients were strictly mitral regurgitation patients who may not be who we're actually seeing in our clinics on a day-to-day basis. However, for effectiveness, you can see here that clearly the MitraClip was beneficial in terms of rehospitalization, and it was safe. Really no device issues beyond the initial 30 days. At 5 years, you see death or hospitalization improved with the clip, and basically every subgroup benefited. All-cause mortality also improved with the clip. And the rest of the details can be found here. But we have to remember that these were highly selected patients. And at least at my site, initially when I was in Louisville, we were 100% screen fail initially because guideline-directed medical therapy worked, and so patients were no longer candidates, or there were anatomic limitations that made the patients not clippable. And so we have to really think about what we had, which was just the classic clip. So maybe with the newer generations and more devices and more choices, the results from COAPT would apply to a broader range of patients. And certainly that's being investigated. And there are many studies showing that the clip benefits patients beyond the COAPT patient. Exactly who they are, we don't know yet. However, it is approved for the high-risk degenerative patients or for secondary patients with COAPT-like anatomy. But how do we apply this to our daily practice? And for those patients who aren't clippable, what do we have to offer? Well, certainly there's also a second clip that maybe we'll find is more applicable to different patients, still an unknown. But it does show in a recent study, manuscript, excuse me, that it does work. It reduces MR and the patients do better. For primary mitral regurgitation, here, this is for just pretty much the high risk or inoperable patients in the United States, and similarly so in the European guidelines. When we look all the way back to the Everest 5-year data, however, we see that in this degenerative group, that the patients who did the best had a reduction of their mitral regurgitation to 1 or mild, and that the patients with more than mild did not do as well. So something to keep in mind as we're going into different patient populations. However, at 5 years, 75% of the surviving patients had mitral regurgitation less than 2+, and 85% of patients remained in New York Heart Association class 1 or 2. So certainly, even though the numbers get quite small out to 5 years, we see an improvement for our degenerative patients. Are we ready for this? Are we ready with the data that we have today, with so many unknowns, to go ahead and randomize patients from surgery versus TEER? Here you can see the design of a trial and what the unknowns are. Looking at a patient population who's older, greater than 75 years, and lower risk, but not low risk, so STS 2% or greater, randomized transcatheter edge-to-edge versus surgical repair. As a surgeon, I'm worried. Remember, many of the patients in the Everest study did not achieve mitral regurgitation mild or less. And thus, maybe we don't know yet who is going to benefit most. I'm going to skip this one for now. Looking at anatomic feasibility, a consensus document that I just briefly passed through shows that some of the limitations and trying to define who is not clippable, anatomic classifications, inadequate reduction, trying to predict which patients are not going to benefit, patient factors, association with inability to perform TEER, and then clinical factors. These are all still unknowns, yet already we're starting to go down the pathway of comparing TEER and degenerative MR to surgery, which has excellent results. And where do the transcatheter replacement techniques fit in? Still all in trials in the United States, although CE marked in Europe. And I know that my colleagues are going to do a deep dive into this, so I won't spend very much time. But we don't know which patients yet should have a replacement versus edge-to-edge repair. So unmet needs in the TEER era, I think this is really more unanswered questions. Do COAPT results apply to non-COAPT patients? Are the results expected to be even better with quote-unquote modern TEER devices? For secondary MR, which patients would be better treated with transcatheter mitral replacement? And who would benefit long-term from TEER, and who should have surgery? All of these are unknown, yet we continue to go down this path. The technology is advancing, and soon, I hope, we'll have some answers to these questions. Thank you.
Of you to start the discussion in this area. So maybe we'll start with DDA. DDA, I think Kendra really highlighted some of the data and some of the challenges where, you know, we still have maybe unpredictable results with TEER. Do you think, you know, when we look at TEER, we have two devices now, and you have them both available in your practice, and you've been using them for some time. This is as good as it gets for TEER, or can we do even better? And if so, what do you think we need to get better results with edge-to-edge repair?
Very critical point that you raised, Azim. So we are achieving very good clinical outcomes with the currently available TEER devices, and we have to acknowledge that. But if we think about mimicking, and I speak under the control of Kendra, if we try to mimic what the surgeons do, it's most of the time in terms of repair, it's a combination of a ring and some leaflet modification techniques, some treatment at the level of the leaflet. So there is conceptually something that is already missing in what we are doing now. And ideally, to potentially be able to treat a broader range of patients, we should be able to combine an efficient annuloplasty technique to a leaflet edge-to-edge repair technique. So there is still room for improvement, but for the time being, we haven't found yet the proper annuloplasty device, transcatheter-wise, to be combined with the Pascal or the MitraClip devices. There's something that we could discuss. I'm sure we're going to discuss during this hour that we're going to spend together, is what are the not suitable anatomies for TEER. I'm still trying to figure it out, and I would like to hear from you guys what you, from your experience, what is not a suitable patient for TEER.
Well, I mean, let's just go with that question, because I think that's a really important question, particularly now that we have two devices as well, right? We have, certainly in my practice, since Pascal has become available, I am doing some cases that I didn't do before with MitraClip, and I'll give a couple examples. So patients with small atria or very low transeptal puncture, where we know it can be sometimes hard to, you know, get the clip down to be able to get a good result. So those are patients I've started trying with Pascal, also patients with high gradients. But I'd love to know from the panel, Kendra, in your practice, I'm sure these cases get discussed as a heart team. Which of the cases you saying, no, we're not going to do TEER here, this will get a suboptimal result?
I think that the discussion usually starts first with the anatomy and whether or not there is a coaptation gap that we do not think we can actually close. And then you go to leaflet morphology, and do you have enough, and oftentimes it's a posterior leaflet, do you have enough posterior leaflet to grasp? How broad is the jet? How redundant are the leaflets? All of the anatomical features are discussed. And not just the leaflets, but also the subvalvular apparatus. You know, in a patient who has restricted cords, are you going to be able to clip the leaflets, but you're not really going to get a good result? And those are patients that we would then be looking for some of the TMVR trials. Concomitant disease often also is another consideration. Yes, you can get a good mitral result, but are they actually suffering from severe tricuspid regurgitation or end-stage heart failure? So there are a lot of different considerations, and that consensus document that I mentioned briefly really does a deep dive into all of those, of what is not clippable.
Yeah, I think thanks to the consensus document, many of us talk about, you know, patients who are in the green zone, those who are clearly in the red zone, and maybe those who are in the sort of yellow zone where we don't know, maybe with more experience you can get good outcomes. But Lars, you know, I remind everybody that you have a lot of experience with TMVR, with replacement. The first, as far as I know, the first ever replacement done on the mitral valve in the world, transcatheter, was done by you. And I'm always reminded about that when I look at how far these technologies have come. You led us on this path. How do you think about, you know, who's the patient who is not a good candidate for repair, and maybe a better candidate for replacement? And are the two always synonymous? if you're a bad patient for repair, does that make you a good case for transcatheter replacement?
It's a good question, Asim, but also remember we just discussed who are the good candidates for TEER and who are candidates where you could expect a less optimal outcome. Today, unfortunately, most sites only have TEER available for transcatheter treatment of these patients. Replacement, we only have one device approved in Europe, the 10-line device. Otherwise, other devices is only under investigation for the time being. So we don't have this complementary treatment option with repair versus replacement. And the patient who we actually turn down for TEER and we look for replacement, also remember there's a very high screen failure. A lot of these patients will not be accepted. So I think we need to get further out to have more devices approved for clinical use and more experience with it, and hopefully also push the border so we can treat more patients with replacement than we can today. The rejection rate, as I said, is pretty high. It's really selected patients which are accepted for it. And I think also that's why we, as a bailout option, are doing TEER on these patients and sometimes see, as I said, a suboptimal outcome.
Yeah, absolutely. I think you highlighted something important, which I'm sure Didier will go through in his next talk on TMVR. But the patients that are in the red zone for TEER are not, by definition, good candidates sometimes for replacement, because what made them a bad candidate for TEER may also make them a bad candidate for replacement, which brings me to ask Holger. Didier mentioned we still need other technologies. Annuloplasty he identified as potentially one of those other technologies that may be important in our toolbox. What are your thoughts about annuloplasty, chordal repair, all these sort of posterior leaflet enhancement technologies, and where do you see them in our toolbox?
Yeah, at least from a theoretical point of view, this makes sense to combine this, because what we do from interventional approaches try to resemble what the surgeons are doing. I know that some sites are combining, for example, the Carillion device for annuloplasty together with MitraClip, or maybe also with the Pascal system. However, this has not been done systematically. I think we have to think about this. At least what I can tell you, so there's also some reimbursement issue if you combine these two things. Nevertheless, this may make sense, but we will have to do trials on this just to give an answer if this really makes sense to combine this. So if we look for the data, what Kendra just has shown to us, so the majority of patients usually are eligible for TEER. I think this is very important, and with further experience what we currently have, we also get much better results than in the beginning, in the 10 years ago when we started to do TEER. So I think this is very important. We have much more experience nowadays, and we are getting much better results. The question, nevertheless, is how sustainable are these results, and if we can even make them more sustainable by combining it. But nevertheless, currently we do not have enough data to really support this in clinical practice.
Yeah, I think you raise great points, Holger. And I think, as we do the discussion today, one of the things I'd love to hear from you work at one of the highest volume mitral tricuspid centers in Germany, Didier in France, Emery as well in Copenhagen, is how do we make these procedures translatable and generalizable? I mean, in America, we like to use the word, how do we democratize these procedures? And so make them accessible to the smaller centers that are doing 20 a year, right? How do we get them to have the same kind of outcomes that we do, and make them more reproducible and consistent? But we'll get back to that in the next discussion. Before we go to the next presentation, we do have a poll for the audience, and we'd love to hear from you and get some of your thoughts in the poll. And so the question in our poll to the audience is there a need for dedicated transcatheter mitral valve implantation devices? Things like replacement, other repair devices. And the options are no, because edge to edge covers most patients. No, because if valve replacement is required, a transcatheter option will never work because of all the limitations we're going to discuss shortly. Or yes, there's an unmet clinical need, or no, I don't know. So please vote, and we'll give you the answers after this next presentation, where Didier is going to take us through TMVR in 2023. Didier.
Okay, so thank you very much, Azim. Sorry for the background. So definitely, I think it's exactly in the scope of the discussion that we had, and you pointed out the fact that this consensus document provided us with some potentially better understanding about how to classify the anatomy of our patients. And from all the mitral patients that we are treating, some may be good candidates for TEER in the green zone. The other ones may be good candidates may not be good candidates, as we have discussed, in the red zone, and in between. We have to find out what is the best strategy. So there is clearly a need to address patients who are not suitable for the approved transcatheter S2H repair therapies. So it's been like 10 years of understanding development of TMVR devices, and you've seen that the very first case that was performed by Lars and his team was more than 10 years ago. Multiple devices have been utilized, but we are slowly moving forward. If you compare to what we have achieved with the MitraClip, we are far behind the number of patients that have been treated with TEER, so there is still a need for improvement. If we think about the patients in the red zone, or potentially the ones in the yellow zone, TMVR could be a suitable option for these patients who are not suitable, 100% suitable for TEER. So if we dive more into the dividing the devices in terms of where they are from a clinical and academic perspective, there are a couple of there are 5 devices that are currently investigated within an active clinical program, and you may clearly highlight and identify that the vast majority of the devices are still under development, and so we need to wait. We will have to wait for additional years to see what are going to be the devices that are going to reach the clinical practice. So if we divide to be a little bit more synthetic, the available devices, or the ones that are into development, into categories, we may have transapical TMVR devices, transeptal TMVR devices, and as a subgroup, the docking system. So if we start with the transapical devices, the most popular one, that is also the one with the broader experience, the greater experience, it's the Tendyne device. You know that device with a D-shaped transapical device that is deployed and attached to the apex with a TEER with a porcine trilift valve inside. The device is fully retrievable, repositionable till a certain point of deployment, and it comes in multiple valve sizes. And most of the patients that have been treated worldwide have been treated with the Tendyne device, and it is CE approved in Europe. So very important. So Tendyne has been tested in a very robust academic clinical program. And the latest clinical trial that is ongoing and currently enrolling is the SUMMIT trial. And as has been evoked by Kendra during the discussion, the Tendyne is going to be in that trial compared to TEER, to MitraClip. So it means that the patient should be still clippable, treatable with TEER. And if it is the case, there is a randomization between Tendyne and a TEER. And for those who are not good candidates for MitraClip, there is going to be a separate arm. So there are still patients who may not be good candidate as we think for a MitraClip, a TEER procedure, MitraClip or Pascal, but even as well for a TMVR. And this is something that is very interesting. MAC is a clear example of patients who may not be suitable for any kind of procedure, and there are a growing body of evidence of utilizing TMVR devices in MAC, and this is an example of the patient treated with a Tendyne in the MAC 1 year after procedure, and you see the function of the valve. So this is something that is really going to expand the scope of patients that could be treated with TMVR in the future. So apart from this transapical device, most of the devices now are transeptal. Apart from being user-friendly, it's that transeptal route really responds to the need of further increasing the outcomes for the patient and preventing these vascular access-related complications when we go from the transapical route. Keeping in mind that these patients are at prohibitive risk, and if we can get rid of the transapical access, it makes sense for them. So it's not an exhaustive list of all the available TMVR devices, but you see that the list is more important than the transapically available devices. So I think one of the most important devices in all this list is the Intrepid platform from Medtronic that has accumulated a quite important number of patients treated worldwide. It has moved from a transapical access to now a transfemoral route with a 29 French delivery system. It's still a surgical cut down to insert the device, but I'm sure that in the future the teams will move to a fully percutaneous approach with the preclosure as we do it on the tricuspid side, for instance. So it's a dual stent design, and the aim is to decouple the inner stent frame, 27 millimeter inner bovine pericardial valve to the brim and the surrounding stents that is going to be more conformable to the anatomy of the patient. Two available sizes, and a very large size is going to be available in the future. More than 300 patients have been treated worldwide. We have spoke about the high rate, rejection rate in terms of screening failure of these patients for TMVR, and potentially having multiple valve sizes, devices with a better profile is going to decrease increase the likelihood of treating our patients with TMVR. So Intrepid has been as well explored for MAC, with good clinical results in highly selected patients. We still need to understand which type of MAC is still feasible, but this is really encouraging as it is for Tendyne as well. So Evoque was one of the very first devices utilized in clinical practice on the mitral side. The cardiac Q device that became the Evoque, and it has evolved. It's more, it has a broader experience on the tricuspid side. There are still some hurdles to overcome on the mitral side, particularly the risk of left ventricular outflow tract obstruction. But the valve as it is designed and the delivery system is extremely ergonomic, and by improving our understanding about the patient selection, potentially we're going to see more and more Evoque cases on the mitral side in the future. And this is a concept that is a bit different from what is generally proposed on the mitral side for TMVR. It's the Alta 4C valve that is going to be expanding transeptally and put into the left atrium. So the idea is to avoid anything that is going to protrude within the left ventricle and increase the risk of left ventricular outflow tract obstruction. And these 14 patients have been treated. You can see that it's a 29 French delivery system. There are still questions relating to the long-term outcomes after these procedures, but from the 14 patients that have been treating, the immediate outcomes in selected patients are quite encouraging. And this could be a way to avoid left ventricular outflow tract obstruction, because as you can see, we are with this device, very large neo-LVOT are observed, and potentially this could be a way to offer something to patients at higher risk of LVOT obstruction with the other devices. So another device that could as well, that has been tested in clinical practice and that could as well minimize the risk of LVOT obstruction, but we need to wait for a larger cohort to confirm the initial findings, is the Sphere TMVR device. That is more or less, it's always the same principle, a two-stent design, and the idea is to protect the inner stent frame from all that surrounds all that is in relation with the mitral apparatus, and to have that conformability, that flexibility, and maintain the valve function by preventing LVOT obstruction, given that very low profile of the stent frame. So the last type, and for the remaining couple of minutes, the last group of devices are the docking systems, and I have selected two of them. The first one that has accumulated a quite decent experience is the HighLife system. The HighLife that initially, once again, was transapical, and that is now transseptal, arterial, and transvenous. So a ring is deployed through retrogradely through the aorta and below the mitral annulus, and then the device itself is deployed transseptally through a fully percutaneous approach. And this is the type of outcomes that we can obtain. There is still that issue of left ventricular outflow tract obstruction, but in properly selected patients, we have good clinical outcomes. And close to 70 patients have been treated. And what we see from these patients is a very efficient device in terms of preventing regurgitation, very low gradient. We need still to understand more about patient selection. The last type of docking system that is in development is the Edwards M3 valve. And here you can see through that transeptal approach the circlage of the mitral apparatus to deploy that docking ring, and then the deployment of the Edwards M3 valve within that ring. Work in progress, but once again, a very promising device. So just to conclude, in a very simple way, we should be able to select between multiple TMVR solutions in the future. There are a couple of devices that have achieved pivotal studies and ID trials that are underway. So we need to wait to see clearly what are the clinical outcomes with these devices. The transeptal solutions, to my opinion, are very, very promising because they really respond to some clinical needs and in terms of clinical outcomes improvement for our patients. And MAC, that has been foreseen as one of the limitations of this therapy, is explored with good clinical outcomes in selected patients. So we need to wait a little bit more. So thank you very much for your attention.
Excellent, Didier. Thank you for that fantastic overview of the TMVR technologies, and I'm sure it's going to spark a lot of discussion. Before we go to the discussion, let's show the poll and see what our audience thinks about what we need in the future. So as you see, hopefully, thank goodness, not surprising, only 6% think we have as good as we need. Majority agree that there's an unmet clinical need, and I guess there's kind of some concern about what that how do we resolve that unmet clinical need? Will it be valves? Will it be other technologies? But clearly, our audience feels strongly that we need other devices for our approach to mitral and to have a better toolbox. So, anything surprise you in the poll, Didier?
No, definitely not, because we have a strong feeling that all the patients that are presented in the clinical trials, they are selected patients, because you can see how important is the selection committee to make sure that these are the most appropriate candidates. And on a daily basis, we are treating patients with a TEER, and at the end, we don't get the expected outcomes in terms of MR reduction. So TMVR is promising for sure, but given the rejection rate that we are seeing today, we can clearly understand that there is something that is missing. We need to understand more about patient selection, and we need potentially more appropriate devices to fully eliminate MR, but as well treat a broader range of patients.
Yeah, so maybe we can dig a little bit more into that, Kendra. We've seen the good of TMVR. We now have transeptal. We really get reduced MR and get rid of MR. But let's maybe talk a little bit about the bad and the ugly of it too. If I remember from that slide, remind me, Lars, when did you do the first TMVR device? I think it was, 2006, somewhere around there?
It was in June 2012.
2012, sorry. So it's 2012. 10 years later. We have one approved device in Europe, which is transapical, and none others that are even close. So 10 years later, it's taken a long time. Maybe, Kendra, for the audience, maybe you can go into some of the reasons why it's been so challenging to get these technologies to our patients.
Well, I think Didier hit on one of the major limitations for the earlier devices, which is the threat of left ventricular outflow tract obstruction. Surgically, we remove the A2 segment of the anterior leaflet so that we won't have that problem. Well, with the devices that were available initially, almost invariably, as they extended into the ventricular side, they pushed the anterior leaflet into the LVOT. And so many patients were excluded for that reason. Now, he did highlight some the Alta valve, which can overcome that, but has its own limitations and is certainly still in early development. So I think that the candidates for the replacements are very, very highly selected. We don't have a device that's going to be able to be like a TAVR where it's one and done, you can put it in anyone. It's just a much more complex pathology. And we have to be reminded, mitral regurgitation doesn't just come in one flavor. And so what is the actual problem with the valve or apparatus or ventricle that needs to be addressed? So because of all those variables, we just haven't come up with the right solution yet.
Absolutely. I think you highlighted, a couple of things: the very high rejection rate, the risk of LV outflow tract obstruction, probably also annular size and the size of the valves. Lars, I mean, you've touched a lot of these technologies. You've been involved in this longer than any of us here, 10 years. I mean, the two main issues I kind of see that are a challenge have been, and the most common reasons for rejection are, as mentioned, LVOT and sizing. When you look at these technologies, do you see a technology that stands out that could overcome that? Or do you think, it's not just going to be a technology, maybe we need to combine the technology with ways of treating the left ventricular outflow tract so that the technologies have a better applicability?
Yeah, we don't have seen any technology yet who at least come forward with a valve in multiple sizes and with no risk of LVOT obstructions. And also, we want to have a device which is very simple to implant. I can see the advantage of a docking station first before you implant the valve, but it's going to make the procedure more complex. So I think we need a device which is also very, very simple to implant into the patient as we move forward. Particularly if you want to see it's going to be like a mainstream therapy addressing a lot of patients. One thing we didn't discuss is also what is the best option for the patient. Let's say we could do the same with a catheter as the surgeons can do. Will repair be a better option for the patient than replacement? I think a surgeon will always try to do a repair if possible. So it's very complex to see what is the role of replacement in transcatheter therapy of mitral valve regurgitation.
Great. I think partly to get and maybe to have it have a bigger role, Holger, I know you had a comment as well, and besides that comment, maybe you can comment on also what we'll need as far as clinical studies to be able to move this field forward. Is it going to be randomized trials? I mean, is it fair to randomize patients to trials when there is a safe, available technology? Just maybe what's your thoughts on the sort of clinical trial really future to get these devices more available?
This is relating also to my comment. So my comment also was that within the last 10 years, regulations became more complicated to get these devices to the market. I think this is also very important, at least in Europe. So medical device regulation rules have become much more complicated, and it makes it much more difficult to do these trials or even do first-in-man studies. I think this is an issue why it takes so long to get also all these devices which are currently in clinical practice, or at least in studies, why it takes so long to get them approved, CE mark approved. And I think this is one major problem which we are facing, at least in Europe. I know that in the United States it's a little bit different. It's much more liberal by the FDA to get first-in-man studies nowadays. I think this is an important issue which also needs to be discussed regarding availability of these devices.
Yeah, I agree with you. I think the early feasibility structure of the FDA has allowed us here in the US to have better availability to new devices, but the pathway to approval is still very long and will require a lot of clinical trials. So right now, we have 2 pivotal trials happening in the United States, one for the Tendyne valve and one for the Intrepid valve. But the Intrepid valve is a single-arm study in patients who are not good candidates for edge-to-edge. So I think that's kind of clear in that group of patients. But I mean, do you think, Holger, we need to do studies in patients who are good candidates for edge-to-edge too? So, I mean, can you envisage a randomized study where we randomize patients to either edge-to-edge or to valve replacement in the future?
We just have seen the study design of, so I think it was a summit trial which Didier has just shown to us. I think at least for very high-risk patients or with borderline anatomic morphologic criteria, we should consider to have a randomized trial with mitral valve replacement versus repair. And we also need it for sure we do not have any interventional options for TEER. But yeah, as you know, I believe in evidence, and we have to do randomized trials in the setting.
Yeah, absolutely. And then we don't have time, but we also have to talk about that group of patients who we do edge-to-edge on and come back with residual MR. And what are we going to do for those patients? That's a really complex group of patients. But let's go on to the next talk, because I don't want to take time away from the live cases. So Holger, thank you for talking to us about the role of transcatheter tricuspid valve therapies in 2023.
Yeah, thank you, Azim. I will try to cover what we have available for tricuspid transcatheter valve replacement, but nevertheless, I will have to cover partly repair because we have the new data from the Teluminate pivotal. These are my disclosures. And so this is what we have available, at least in clinical trials. Sometimes it's also already CE mark, also approved in the United States for repair. What we have available is a Pascal device as well as a MitraClip device. And we have several other options for the treatment of tricuspid regurgitation. Regarding valve, you can see there's an evolution from different valves which have been at least assessed in some first-in-man trials sometimes. So you can see it here. We have refined valves like the cardio valve, which I will cover in some cases, which I will show to you, and also the Evoke valve, which is currently under investigation also in studies. But First of all, we very similar to the mitral valve. We have to make considerations also regarding tricuspid valve. As you all know, with the mitral clip, also the Pascal device, it's commercially available. It's safe, which has been shown in many registry studies, and you can use it in many patients, and it's effective. It's durable. Nevertheless, we also have, regarding effectiveness, some limitations also regarding durability and anatomic feasibility. There are also limitations with the edge-to-edge approach for the tricuspid valve. You will see from our center in the next hour some cases regarding or one case regarding the Pascal device in patients with severe tricuspid regurgitation. You all know how we are doing it nowadays. You can see this for this patient, where it worked really very fine with also some annulus adaptation by this device in this case. And this is what you can see here. There's also an indirect annuloplasty by edge-to-edge repair. As you can see it here from the deep transcatheter view in TOE. And by this, what you can see, we can reduce torrential tricuspid regurgitation to grade 1 tricuspid regurgitation. And we all know that many patients can be treated by this. Probably the most important thing is looking for morphologic suitability for the edge-to-edge repair. Probably very important is the critical gap width, which should not be more than 10 millimeters. But nevertheless, with the introduction of the Pascal device, we have more options by independent leaflet grasping. Nevertheless, this is usually what we consider where we have a good result. It should be less than 10 millimeters in the critical gap. There are proposals on how to approach this regarding device selection. So we also have to look if it is lead related, if it is primary, if it is secondary. Then we will have to make considerations when to use TEER, when to use a possible replacement approach. And these are also very important options. So 4 leaflets, we have learned about anatomy, lead-induced tricuspid regurgitation, where we have to consider if this is treatable by TEER. So outcome data, this is also important. After the Triluminate pivotal, I just show you the data. We had a significant reduction in TEER severity, which has just been presented during ACC. Everybody has been waiting for this randomized trial because it's the first randomized trial which has been mainly performed in centers in the United States. So it was a positive trial, but nevertheless, there were lots of discussions, in particular on Twitter, because we haven't seen any reduction in death or tricuspid valve surgery, no reduction, significant reduction in heart failure hospitalization, because they used a win ratio approach. Nevertheless, they were able to show a significant improvement in quality of life according to this questionnaire, which has been used in this randomized trial. I think this is what everybody is discussing. Maybe it's because the patients included were relatively healthy, because they were younger, because there were selection in particular of easy cases for tricuspid TEER. And maybe that's one of the reasons why there were no reduction in heart failure hospitalization or mortality or tricuspid valve surgery. Nevertheless, it's important that quality of life has been improved, as you can see it here. And there was a clear relation between the reduction in tricuspid regurgitation and the improvement in quality of life, just underlining that there seems to be a clear benefit by tricuspid regurgitation treatment by TEER in comparison to the control. Now, looking Also for ongoing trials, there are many ongoing trials. We now have the triluminate pivotal trials. There are 4 other randomized trials which are ongoing. And as you can see here, the largest will be this trial with 825 patients to be included. But nevertheless, we have to wait for the results. And we also have to wait for longer follow-up of the triluminate pivotal trial, which was still a relatively small trial. Now, hypothetical considerations regarding tricuspid valve replacement are that we have a better tricuspid regurgitation reduction. It also works in tethering. Nevertheless, we may also have limitations regarding annular limitations, RV failure, thrombosis, bleeding, AV block. There was one valve which had 100% AV block grade 3 after the insertion of the intraport valve. So this is what we also have to consider. And currently, we have several valves which are under investigation. So that's the Evoke tricuspid valve replacement system, as you can see it here, with different sizes, much larger than we know it from TAVR valves, 44, 48, and 52 millimeters. They are inserted by a venous approach, as you can see it here. I will show you a case from our center where you can see it here, where it worked really very nice, where there was a reduction from torrential regurgitation to really no or trace tricuspid regurgitation after the implantation of the Evoke trial, of the Evoke valve, as you can see it here. So this is what we can see from studies. You can see it here. There's really, in the majority, there's no tricuspid regurgitation afterwards, or only mild or trace regurgitation. So this really works. And as you can see here, 98% had only mild or no tricuspid regurgitation at follow-up. There's another valve, the cardio valve, which also mimics a proven surgical valve design. As you can see it here, it's also transfemoral approach, venous approach, no radial forces. It has PVL sealing. It fits also at different anatomies up to 55 millimeters, as you can see it here, because it has 3 different sizes, medium, large, and extra large, also for patients with very large RVs, so that you can accommodate the different sizes to also the RV and the annulus of the tricuspid annulus. One case from my former place where I've worked formerly in Lübeck, it's the University of Lübeck, where you can see it here. You can see how it is inserted. Interestingly, you can see also here this valve is also suitable for the mitral position, as you can see it here. So we have 2 cardio valves in place for the mitral as well as for the tricuspid situations. This was the first case where both AV valves were treated by the cardiac valve, as you can see it here. So this is the way it works. Also a case with only mild or no regurgitation after the insertion of the cardio valve in this particular patient. So there's some data from the compassionate special access initial study. As you can see it here, 20 patients, altogether 80 years, extremely sick patients with severe TR, massive and torrential, as you can see it here. And these are the valve sizes which have been used. Usually you need large or extra large valves for the insertion or treatment of tricuspid regurgitation in these particular patients. And you can see it very similar to the Evoke trial, that there's a significant reduction in significant tricuspid regurgitation. The majority of the patients have no regurgitation afterwards, and only a few patients have moderate, and only 1 patient had still massive regurgitation after the treatment with this cardio valve. There's the target study, which is currently or close to be started. It's also a prospective single-arm study, no randomized trial, as what we have discussed before. And the aim is to enroll overall 100 subjects at 40 investigational sites in Germany, Spain, Italy, and Canada. follow-up will be up to 5 years. So we have to wait for this data until we have also CE mark approval for commercial use of this specific valve in the future. So in conclusion, the TEER is super safe, well tolerated by patients, preserves RV function. Usually we do not need vitamin K antagonists, very little foreign material. We have improvement of quality of life, as I've shown to you from the Triluminate pivotal trial, but it's not always working in every patient. That's the reason why we probably need valves which are super effective. It's a relatively easy procedure. There are concerns regarding AV block, high bleeding risk, endocarditis, or maybe also thrombosis, and RV failure, in particular for patients with severe impaired right ventricular function. So at the end, I would like to thank you. I think this is maybe the way what we are currently doing. If we are able to have a good repair, this is what we do. Otherwise, we will have to consider replacement because this is much better than a bad repair in this situation. That's the reason why we have to look for the suitability and the valve morphology, if it can be treated by TEER. Nevertheless, there's more than a niche for valve replacement also in the tricuspid position. Thank you very much.
Holger, that's fantastic. Thank you. What a great presentation. I loved your conclusion slide, which really summarizes, I think, the benefits and challenges of edge-to-edge versus replacement. And it's clear you work with a good surgeon, Michael Borger, because I see you already starting to steal some of his lines. Our surgeons love to say a good repair is better than replacement, which is better than a bad repair. Our surgeons love that line too. But I think it's something we can learn from it. I wish we had time to dig in a little bit into the Triluminate data and understand from the four of you how you interpret that data and what impact it will have in the field. But maybe you can mention some of your comments as we look through the live cases. But really, our format here at TIO is give you some state-of-the-art presentations on where the field is. And I think we've seen that. We've talked about the unmet needs with edge-to-edge repair and why we need other therapies. We saw a great overview of valve replacement and all the technologies for valve replacement, and also this really growing field of tricuspid, which is going to be filled with randomized trials coming out within the next few years, looking at repair devices, replacement devices, and I think is going to be very exciting. But to really take this home and keeping the format of TIO, we always match this with great live cases, and that's what we'll go to next. We have some fantastic live cases for you on a tricuspid as well as a mitral. I'm going to leave it up to the operators to introduce their cases and not spoil the surprise, and as we go to our live case centers in Leipzig and Dortmund.